over the last few months, we've seen a dramatic change in the way that everything's happened from a healthcare perspective during the pandemic. Nurses have been critical during the pandemic and before in helping patients, make decisions around treatment, education. And Kelly, I just was curious, from your perspective, how has the treatment of IBD changed during the pandemic? Have you seen any nuances, change in patterns, the way people are prescribed certain drugs, or is it kind of the same today as it was 3 months ago?
No, I think it's a little different. First of all, most of our care is being provided virtually. So for our patients, that's a big change. And a change for us as well that we're all adapting to and working with. Patients, in order to assess patients, we're doing fewer colonoscopies, so fewer procedures, and we're relying much more heavily on fecal calprotectin to tell us if disease is active or if patients need a change in management. Our access to colonoscopy in Nova Scotia, at least, has been limited to just very severe and very urgent cases. So I find that, much more frequently, I'm just relying on fecal calprotectin and blood work to make decisions. We're working very hard to try to avoid the use of steroids and prednisone because we do believe that being on prednisone or steroids, if you do contract COVID, that you have a higher risk of a poorer outcome. So we are trying to avoid steroids in most patients. And in order to do that, sometimes we're initiating biologics a little bit faster. We're using other steroids like budesonide, Entecort, and Cortiment in order to try to prevent the use of prednisone for our patients. So, it's interesting because without seeing patients, we're actually getting them started onto biologics quicker because we're trying to avoid using steroids. Patients who are already on biologic therapy, they're on combination therapy. So if they're on a biologic plus an immunosuppressant like Imuran or methotrexate, if patients are very well and stable and we know that they have a good remission, if their blood work is normal and their fecal cal is normal, we are considering removing the immunosuppressant part of the treatment regime, not because we think there's any evidence that immunosuppressants increase your risks with COVID, but we do know that they do affect other viruses, and we're just being a little bit cautious with that, particularly in high-risk groups with COVID-19, like elderly individuals. Patients who are on biologics, we had concerns in the beginning about biologics and their effects if patients were to contract COVID, but we've become much more comfortable as the evidence has rolled in that the best course is for patients to stay on their biologic therapy. And what we're learning, or what we think we know now, is active disease is actually one of the high risk factors when patients contract COVID. So it's better for their disease to be in remission, and it's more likely for the disease to be in remission if they're on their therapy. So that type of information helps patients certainly to make decisions about therapy. Patients who are very reluctant to start a biologic, if you say, well, actually the risk of active disease for you right now is higher, it makes the decision easier. It helps them to move forward with starting biologic therapy. So those are the main ways I think that others may have noticed different things, but those are the main trends that I seem to have seen with changes in therapy as we've moved through this pandemic.
Yeah, Kelly, I don't think I could have said that any more eloquently. Thank you so much. That was so clear. And maybe to Karen, from your perspective, from a pediatric perspective, you heard Kelly kind of mention the whole idea of trying to minimize the use of prednisone. And I agree, in the adult world, we are kind of shifting towards using more of the biologics to try to minimize the need to use steroids at higher doses and for longer, or potentially avoid it outright. Are there different things that you can do in a pediatric population?
Yes, certainly. So that was a nice segue, Kelly, to what I'm about to talk about. So we have another treatment in our armamentarium that is a plus for us, because not that it's an easy sell, but it's something that pediatric patients and their families have heard of, and that is enteral therapy, or enteral nutrition therapy. And so what that is a formula-based treatment. It could be given sort of exclusively, meaning that's the only intake a patient would have for, say, 6 to 8 weeks or so, or it could be given supplementally, in that they eat part of the day and eat some formula-based therapy for the rest of the day. So in a lot of ways, it's a really good sell to families when we describe the risk that a patient may be put on if we put them on steroid therapy. So in that sense, we do get buy-in from the families, and really, once we have described what the therapy is like and what the support system is like, patients who qualify, so they have to sort of fit the criteria. So we hardly would prescribe enteral nutrition therapy to ulcerative colitis patients, more so for Crohn's disease patients. And really, if the disease is manageable through EM therapy, then it's something that we would do. So again, the plus side to that is being able to spare the patients from using steroid. And of course, when I speak about the plus side, I also have to talk about sort of a bit of downside is, of course, telling parents or families that EM therapy could be for 6 to 8 weeks, but the beginning part is also a bit of a challenge in that there's really a 2 or 3 day stay in the hospital. So either in a short stay unit, or if they were admitted, then we would do it right there. So I think the panel had agreed earlier on that trying to bring patients into a hospital is, is a bit of anxiety provoking for them. But once they sort of see what the outcome could be, then it's sort of an easier sell. So that's one thing that pediatrics have that we can sort of sell easier than adults, I think, is EM therapy.
Yeah, that really depends on the center as well, right? So not all places need to admit the patient to teach them how to use a nasogastric tube in the pump. They can sometimes do it in an outpatient clinic.
Yes.
And also, if the patient is willing to drink the formula, that's an option as well without need for a pump or for a tube. But the problem we have in Ontario anyway is that insurance companies don't cover the treatment unless it's delivered through a nasogastric tube.
That's exactly
so that
it.
becomes difficult. So there's lots of, there's some barriers to that, but it is definitely a nice alternative to using steroids.
Mm-hmm. And you're quite right, Eric. We actually do have a day unit where patients would come in the morning and then leave at night. And there's a great team of dietitian and registered nurses and educator who would guide them through the process.
And is that open during the COVID-19 pandemic?
Yes.
Or it is great?
Yeah.